Hello, folks. Thanks for joining us on Head Inside Mental Health, featuring conversations about mental health and substance use treatment with experts, advocates, and professionals from across the country, sharing their thoughts and insights on the world of behavioral health care. Broadcasting on WPVM 1037, the voice of Asheville, independent, commercial-free radio. I'm Todd Weatherly, your host, therapeutic consultant and behavioral health expert. With me today is friend and colleague, Dr. David Rowe. Dr. Rowe is the Executive Director of Neuropsychology at United Assessment, a nationwide evaluation service offering comprehensive neuropsychological, psychoeducational, psychodiagnostic, psychosexual, sexual, forensic, and developmental testing for clients across the lifespan. Under Dr. Rowe's leadership, United Assessment has grown into a trusted resource for families, educators, legal professionals, and clinicians, delivering data-driven evaluations that inform clear, actionable outcomes. In addition to this, United Assessment, Dr. Rowe serves as an assessment supervisor at Andrus Children's Center, an APA-accredited community mental health clinic, and holds faculty appointments with both Columbia University and the William Allinston White Institute, where he supervises psychological assessment in the child and adolescent program. A dedicated educator and researcher, Dr. Rowe teaches courses in child psychology, abnormal psychology, and psychology, and continues to conduct clinical research with a focus on novel, pharmaceutical, and behavioral interventions for individuals with severe psychopathology. Moving forward, Dr. Rowe is committed to continuing to build scalable, gold standard assessment service that bridge the gap between clinical excellence and accessibility. Doc, welcome to the show.
Thanks for having me, Todd. I really appreciate it.
Absolutely. He's also, like, I would add to the bio, he's also a pretty nice guy and fun to hang out with.
Thank you so much. All right. Solid conversationalist.
I'll caveat that with, if you can keep up with him. One of the fastest minds I've ever run into. I'm like, hold on, let me see if I caught all those words he said on that. Like, I've just, there are people gifted with the ability to speak quickly, complex terminology. Rappers seem to be one of them. And for some, you got like this gift for saying a lot of really dense content in a very short period of time. I'm in awe. When the first time I met you in person, you were standing up. We all had to talk about what we did and who we are. And it's like, I'm Dr. David Rowe. And you were like, you sound like the guy at the end of the disclaimer message for a radio show.
Yeah.
I'm like, oh,
Batteries
wow,
not included,
you did all that in like a second?
Yeah. I almost went to auctioneering, and then last minute, I said neuropsychology.
It's quite the divide there.
Yeah, it's quite the divide.
I think you could do a little bit of both. If you get a little side gig,
Never too late. Never too late to be an auctioneer.
Well, and in light of that, and part of the reason why we know about your services, my team has used your services before, referred you out to folks, and every time that we meet families that are, most of the time they're in crisis, a lot of times the person has a lot of co-occurring conditions, there's a lot of complexity involved and everything else. That's part of where we live in the world. Those are the people that we meet, the families that are struggling to figure out what to do. And like, what do we do? I say, well, how about we get somebody to actually tell us what's going on? How about we get a really good assessment before we decide what treatment we're going to use? And I think that it takes people aback a bit. It's like, well, went to the hospital and he's got this diagnosis, or she, or whatever. They've got all this clinical history, but it comes from emergency care. It might come from outpatient care. It might be something a psychiatrist said, or something that a clinician was willing to hang their hat on. And then I have to go into explaining the difference between a social worker doing a biopsychosocial evaluation on a person who's just come into a center. They spent an hour maybe, and they did maybe a couple of assessments or asked some questions, did a biopsychosocial review. Out of that, some doc looked at it and they came away with a diagnosis. The difference between that and what I would call a true assessment, a neuropsychological assessment that's going to cross a lot of territory and even investigate specifically if there's indicators to do so. And I really have to tell families what the difference is in that. What is it like when you get a family that's coming to you, or a client that's coming to you that's looking for assessment? Do you run into that? And what's your answer to that question? How would you differentiate what the rest of the world thinks of diagnosis and what real assessment looks like? What's the answer to that question for you when you're talking to folks?
That's a great question. I think that most people's foray into diagnosis is like knowing somebody who just took a Psych 101 class in college and is learning about the symptoms and the criteria and diagnosing themselves and their friends and their families. And the reality is, like, biopsychosocials are a really helpful tool. Psychiatric evaluations are a really helpful tool, but so much of it relies on subjectivity, which is to say it's inferential, it's impressionistic, right? And psychology doesn't have to be a soft science. And part of neuropsychological testing is bringing empirical data back to diagnostics. So when someone's doing a biopsychosocial, they're doing a psychiatric interview, they're meeting with somebody 15, 30, 45, 60 minutes. They're collecting a lot of information. Largely, it's qualitative. And neuropsychological testing couldn't be more different. These tests have been iterated upon for decades. They've been norm referenced on tens of thousands of people that client's age. It's the best way we have in the field of psychiatry, psychology of arriving at a accurate, valid, reliable diagnosis. So we're testing for everything from cognitive disorders, attentional disorders, learning disorders to depression, anxiety, bipolarity, psychosis, disordered eating, OCD, trauma, personality disorders, autism, substance issues, the whole gamut. So when we get to the end, we don't just know what's going on for someone, we've successfully ruled out everything else. And to your point, when you're approaching somebody, especially when they're in crisis, more often than not, your subjective account of what's going on with them is not a good read on that person. You're seeing them at the worst moments in their life in an unfamiliar environment, oftentimes under enormous, tremendous stress. And then someone along the way may have assigned them a diagnosis, and that diagnosis gets entered into a chart, and then something really interesting happens. Everybody downstream starts looking at that person through that lens. If the chart says bipolar disorder, we start interpreting that behavior as bipolar disorder. If the chart says borderline personality disorder, we start interpreting the same behavior very differently. If it says ADHD or autism or depression or oppositional behavior, that label starts organizing what we're looking for and how to help them. But the problem isn't diagnosis, because diagnosis can be enormously helpful as a heuristic to really, again, help organize someone's care. The problem is when a provisional explanation becomes an unquestioned fact. Does that make sense?
Right. Yeah, absolutely. When if a professional comes and, they see the evidence or the diagnosis and suddenly they're entrained, they're, and I, when this is going to be an interesting story for you. When my first job, undergrad in psych, first job, um, wilderness camp for adolescent kids, court referred and everything else. We had a psychiatrist who was researching bipolar disorder. And suddenly all of our kids starting having a diagnosis of bipolar disorder. And then they get put on the same meds and their clinical profile looks the same and their treatment looks the same, or their, clinical documentation and how we're going to access treatment for this person, what they're going to go do after that all starts to look the same for everybody. And suddenly it's a camp full of these kids. And it's like, it's not it. Fast forward to another situation where I've got a person going for a residential assessment, and everybody said this about them. It's thought disorder. Everybody knows it's thought disorders, everything else. They dig in a little deeper and all of a sudden they discover it's like, look, this person's got pretty severe OCD. And while what looks like delusion is actually OCD gone awry.
Yeah.
They live way far in their own brain. And it was like, it changed the whole treatment approach that we had with the person.
100%. There's so much symptomological overlap. I get people call me every day that say, can you just do the gold standard test for ADHD? And I said I could, but the reality is inattention is symptomatic of a dozen different disorders in the DSM. So it could be
Right.
development like ADHD, but it could be psychiatric causing cognitive interference. It could be anxiety or depression or trauma or OCD or anything that can compromise your attentional faculties. And if you're not going to be able to hold those variables constant, then you can't actually get a good sense of what's causing it. We're not there to invalidate someone's experience of inattention. I'm sure they're inattentive. We're there to evaluate the etiology of that inattention. What is causing it? So I think that when your formulation is wrong, or quite frankly, even incomplete, we can end up delivering really good treatment for the wrong problem, right? And at the end of the day, you're never going to get better if you're putting foot cream on a headache. You know what I mean?
I don't know. Maybe,
Maybe. I don't know. I don't know. It's good work, but we're trying, I suppose, if it's no downside. But in this case, there could be. In this case, they be colossal downside. And I
Well,
think
you end
that
up throwing spaghetti at the wall, you know what I mean? So,
yeah, and trial and error is so painful for everyone, for the client, for the family, for the provider. When you're effectively having to adjust the neurochemistry, especially of the adolescents you worked with in the wilderness setting, that's a painful process, right? And or if you're doing trial and error with someone's treatment, it's exhausting in terms of time and money and effort
oh
and
my gosh.
energy.
Well, then you have to reset every time you discover something new. You know, the thing that you said about, people going into hospitals or in their crisis situation, and largely what's coming out of it is inferential. You know, in addition to that, the inference is being made on self-report data. And if you let's talk about thought disorder. Well, thought thought disorder has an impact on self-report. Like the reliability of self-report from a person suffering from schizophrenia is questionable at best. At worst, it's all kinds of other things. And so if you're walking in there making inferential diagnoses based on self-report, I mean, heck, many of the clients that we have can talk to you about parents are super frustrated because the clients came in. It's like, I'm okay and I don't want to hurt myself. And they walk out and that's the first thing they do because they know how to say whatever it is they need to say and they can walk out, or they're saying things that are completely immersed in delusion. When you are faced with clients, like the complexity, I think I got a lot of listeners that would love to hear this answer, and I want to hear it from you specifically. When you're diving into something that feels complex, where do you start? Like as a career and somebody who I respect a lot as a diagnostician, where do you start with somebody who's already presenting with a lot of complex behaviors?
You start with a clinical interview the same way you would if you were a social worker, a psychiatrist, a psychologist, because the most important thing you can do to start neuropsych testing is build rapport. Everything in this field, everything in life, I would argue, is about relationships. I mean, this goes back 2,000 years to the philosophical question, is there a self without the other? So I'm sitting there with them and I need to engage them in the conversation. I need them to be appropriately effortful. I need them to try their best and to try to be open and honest and forthright. And sometimes there is a thought disorder. And that's why we don't just rely on subjective account, right? We also use objective and projective testing. So like a classic would be the Rorschach. It has contemporary standardized approach. And some people say people still use the ink blot test. And I say, of course, because
You got to get tatted. Look, you just
because
got
we
to get
can
tatted.
evaluate, yeah, we can evaluate aspects of thought and perception that can be so much more difficult to appreciate through self-report, right? So like these tests again have been validated. So we're looking for like distorted perceptions and reality testing. We're asking, does this person repeatedly perceive things in ways that are poorly anchored, right, to the world around them? We're looking for disorganized reasoning. We're asking, do responses that they're providing contain illogical relationships, contradictions, implausible combinations, breakdowns in like ordinary reasoning? And we can
Mm-hmm.
see that through even something like the inkblot test. And we're not even doing a singular test. We're looking for convergent validity, which means we're doing more than one test. That way we know that when we get to the end, we have the highest statistical likelihood of accuracy, right? And the same thing can be said of a bunch of other different variables. Loose or kind of idiosyncratic associations. Does this person make connections that are unusually difficult to follow or very highly personalized to them? Communication disturbances, boundary and integration problems. And we even have the question, what's the duration? What's the severity? What's the frequency of these behaviors? One unusual response means very little. A repeated pattern of significant disturbances is much more clinically meaningful. Does that answer your question?
Well, yeah, and I think I was about to ask this question and then you answered it anyway, or at least I think this is the answer to this question. Like, what's the difference between the doc in the hospital that's walking in 20 minutes, writing some things down, looking at the biopsychosocial review assessment that somebody else did, and then coming away, making some inferences and coming away with a diagnosis? What's the difference between that very erroneous system, oftentimes, as evidence would indicate, and what you're talking about? And I think that the difference is that you said, I need to have a relationship with this person. I need to have their trust. I need to have a
Yeah.
connection to them. And their
And
their aim is not to do that when they walk in that room.
that's it. We have very different goals and we're trying to answer very different questions, right? Any psychiatric hospital any psychiatrist working in an inpatient unit is asking, what's happening right now? Is this person safe? How do we stabilize them? Right? That's like their the primary goal. As a neuropsychologist, I have the luxury of asking, first of all, of the luxury of time. And secondly, I have the luxury of asking them, who is this person when they're in crisis and when they're not? How did they get here? And what best explains the entire developmental and clinical picture? At the end of the day, we're trying to do the impossible. We're trying to construct an explanatory model of a person, right? And the distinction is important because families, like as I said, arrive asking, does my child have ADHD? Do they have a thought disorder? Is this autism? But the better question is, what is happening here? Why is it happening? And what does this person need?
Yeah. As opposed to approaching it with a diagnosis in mind already, as you say, like that's going to flavor everything you see.
When all you have is a hammer, everything looks like a nail. That's true. That happens when all of a sudden everybody has a bipolar diagnosis sometimes. Not to
Oh my
cast
gosh.
aspersions.
Right. Well,
Yeah.
and the other piece, and I think that it's entirely possible that, forming a therapeutic alliance with the individual answers this question as well, which is, when we see people in crisis, a lot of times it's like, hey, we were talking about this, they need to stabilize a bit before we can really, because all these big, loud symptoms are screaming so loud, everything that's underneath it is muted. We can't see it.
A hundred
When
percent.
when you've got, I know that you get clients, even though you're not doing assessments in a residential setting. I know you get a lot of clients that are in a lot of distress. They've got a lot of symptomology going on. Even if they're not in the hospital, they probably could be in a residential treatment environment where they're going to get very substantial care, clinical care. When you're encountering someone who is highly dysregulated and highly symptomatic, what's the approach that you take? I know that you're trying to get a relationship, trying to also get a really good read on this person. What's the approach that you take in getting to that place where you feel like you can get in underneath the surface and figure out what's going on?
Honestly, time is everything. Giving people time, giving people
Mm.
attention, giving people what they need in that moment. Again, people are usually in unfamiliar settings and they're very, very distressed and they need a calming, reaffirming, and patient approach. At the end, and you said it perfectly, which is they can be really, really behaviorally dysregulated. And behavior tells you what's happening, but doesn't tell you why it's happening, right? The symptom is like the smoke, not the fire. And we're trying to figure out what the fire is. So we do testing
Right.
on it's true. We do testing inpatient, outpatient. We do testing in residential facilities all over the country, testing people's homes. We do testing anywhere anybody, is and where they need it. Um, and what we tend to find is when we have, again, the luxury of being able to do testing during a moment of crisis, when people are inpatient, it helps to inform the stabilization process. So sometimes people erroneously believe that you have to wait until someone's
Mm.
stabilized to do testing. But that doesn't actually make a lot of sense. Then you're doing trial and error during the most important part of the process. First of all,
You don't
doing
want to
testing,
miss it. Right.
you don't miss it. I mean, first of all, we get a good sense of the way in which this acuity is affecting the person, how it's dysregulating them, how it's impacting their functionality. And then two, we want to get an understanding of, for example, is this bipolar 1 with psychotic features, or is this schizoaffective disorder? Two very similar disorders in terms of behavior, two very different treatment approaches. So
Right.
at the end of the day, we want to be able to get good clinical information so people can make informed clinical decisions as soon as possible. So as long as they are being appropriately effortful and we have validity indicators built within the algorithms of the test themselves, we're able to kind of move ahead with testing and give a lot of good information to that inpatient team so they can inform medication considerations, therapeutic interventions, behavioral controls. I mean, I've seen people in
Treatment
crisis
placement.
treatment placement, what level of care
Right.
do they need? I mean, there's
Right.
times when people are inpatient and it has a greater iatrogenic effect than it should, which is to say maybe they are experiencing paranoia or a thought disorder or a delusion. And by virtue of being locked up and getting 15-minute checks and having a camera in the room, it's making their condition worse, not better. Right. And we need to be
Yeah.
able to consider all of the factors. And a good neuropsychologist can help you with all of that.
Yeah, I tend to think of residential treatment very often, though not all of them are this way. They can feel like pressure cookers.
We can.
Um, and there are some people who need that kind of intensive level of approach because you got to get to the root of it, and they
Right.
benefit from those kinds of treatment environments. And then there are others who just like it's too much. It's just way too much.
Oh, there's nothing more important than fit. Fit is everything.
Yeah.
It's the same as getting a personal trainer, right? You want to make sure that somebody's not going to push you too hard to where you hurt yourself and not kind of push you light enough to where it's a waste of your time and money, right? There's a lid for every pot, especially in treatment, and that's why we say, you don't have to find every modality that works for you. You have to find one that works for you. Same with mindfulness practices, with level of care, all those kinds of things.
Well, now let's broaden ever so slightly. Let's because I'm pretty interested in the kind of the metadata here. I would say that for the company that you've built and the approach that you take, you've got you guys are all over the nation. I know a few other, psychology or clinical psychologists that are out there doing assessments, and they travel the country and they hit this and that, and they may work with programs and so on. But I think you've got broader reach than anybody I know. So that means that, in some of the ways it makes a good consultant valuable to a person because they've been everywhere and they've seen placement and they've seen enough conditions and they know what they're doing, they know who to find, etc. When you're doing assessments, what are you seeing on the metadata? Like, are you seeing more acuity out there? What are you encountering with the people that are coming to you for assessment? Like, what has been and you're probably on the side of treatment as well because you're seeing people in residential environments and everything else. I think that our field, that is treatment field for primary mental health conditions, co-occurring substance use conditions, has done a pretty significant shift in the last 5, say 10 years. What would you say that shift is towards? What is it that has caused the shift? Do you agree that it has shifted? Like what are you seeing us going right now in the world of mental health care, assessment, treatment, etc.?
So I will say that like a proud statistician and diagnostician, I try not to make like, subjective conjecture on trends without appropriate data.
Well, my job
So
is to make you step out on a limb here.
I
So
know. So I'm happy to kind of share anecdotally. The thing that we're encountering is acuity, like certainly, but I think an even better word is complexity. Acuity and complexity are both very much on the rise. We're seeing young people who don't come to us with one clean problem anymore. They arrive with 4 or 5 diagnoses, with multiple medication trials, with previous hospitalizations, school failures, school refusal, significant family systems distress, like years of treatment. And sometimes those diagnoses are correct, and sometimes we then have to reconstruct their developmental history and do comprehensive testing, and we realize that those diagnoses don't fully explain a person. But in terms of trends, we do see an enormous amount of overlap. We see ADHD with anxiety. We see autism with OCD. I mean, I will say that there's been a lot more recognition of autism, especially in people assigned female at birth. Um, it's not that necessarily the prevalence rate has gone up, but that the incidence rate, which is to say, like the acknowledgement of it, the diagnosis of it, because we understand it a little bit better, and that happens over time. Um, so more and more people are understanding what neurodivergence means in our society. It's becoming easier to talk about, more normalized. So people are wondering about themselves, and I think that that's a really wonderful thing. More and more patients are asking questions and are invested and interested in learning. And I think that's a good trend to go with the kind of more scary trend of increased acuity and complexity.
yeah, and since you hit the neurodivergent topic, let's. I just recently and I went and presented at the Autism Research Symposium, and the thrust of mine was not only is there a care continuum that you want to be careful to observe, you also want to assess properly and everything else. And finally, because our sophistication around this topic has increased, you can't treat ASD the way you treat mental health. Looks like borderline, it's not. And if you treat it the way, which is why you get this phenomenon where you've got some kid on the spectrum and they could walk in and write a book and teach a class on CBT or DBT techniques and everything else. Like they are expert, but they couldn't use a DBT skill to save their life. They walk out dysregulated, they walk out overwhelmed, and it doesn't land for them because the modality doesn't address their need. When you're doing when you're doing the assessments and you're finding people who are on the spectrum or on the neurodivergent spectrum, I know that part of the work that you're doing is also communicating to families in a way they understand. Like, what is it? What's the message like to a family who finds their child or a loved one, and maybe it's an adult that's on the spectrum, and trying to figure out what that means to their life. Like, how are you talking to families about this?
Yeah, it's a great question. I mean, first and foremost, we have to help them understand their historical experience. Most of the time, by the time I'm doing an evaluation and we're the ones giving the initial autism diagnosis, it's not for 3 or 4 year olds, it's for 23 and 24-year-olds, right? For people who
Right.
are functioning well through society. Maybe they transitioned to early adulthood and went through that very sensitive developmental change and they were no longer able to function. Maybe it's that point where the demands of life in terms of increased complexity, relationships, vocational demands exceeded their capacities. And then they didn't know what to do. Maybe they had friends through their cohort from K through 12, and they were in structured opportunities for social engagement like sports, and then they transitioned to college and they couldn't figure out how to make new friends, and that they couldn't hit the ground running like they really wanted to. But the reality is, when people find out that they might have a developmental disorder, right? They might have like an autism spectrum disorder, you really attempt to try to provide like a framework, a lens through which to interpret their history, the rest of their life, which is to say,
Mhm.
maybe you weren't able to get your needs met, right? Maybe you struggle to feel like you fit in, or really struggle to feel like a person at all. And when that happens, all of those things can aggregate, all those little traumas can aggregate and internalize into kind of a significant, relational rift. Does that make sense? So what
Yeah,
ends up
yeah,
happening is,
absolutely does.
say, so when people have things like they come into us for depression, they come into us for anxiety, and we see that, and obviously we want to treat them for that. But maybe there's a foundational reason why they're experiencing that depression and anxiety. I know that if anybody isn't getting their needs met, especially their social needs, they're going to experience depression and anxiety because people on the spectrum, just like people not on the spectrum, want what everybody wants mostly, which is to love and be loved. And when you're
Right.
not getting that, you're going to feel anxious. You're going to feel depressed. You might develop some characterological symptoms, right? I mean, there are people who become very, very internalized and say, the world rejected me. I'm going to reject it. I want everyone to leave me alone. You might become very externalized. The world feels like it's constantly rejecting me. I'm going to constantly seek validation. Maybe they turn to substances to self-medicate, like so many people with depression and anxiety. And then it becomes a complicated clinical picture. So if we can understand that they have this foundational developmental disorder, then we can really kind of help them reinterpret so much in their life to have a better relationship with their past, kind of shore up their resources, have a kind of make better decisions in the present, and as insipid as it might sound, have a brighter future.
Psychological conditions, the best analogy I can think of is it's like an ecosystem. It's like you've got this factor over here, but it's influenced by this factor. If you remove this factor, these factors, there's all these pieces that are interdependent on one another. And when you're, sussing it out and you're figuring it out, you want to find the drivers, of course, but you also, it's like, and through your life, you've done all these things. Family came to me just the other day and they were like, well, he was in the hospital for 2 months. I said, well, if you didn't have a mental health condition before he went in the hospital, he does now. Um, because that environment is just not one that's, I mean, it's not supportive. It's not a place where you're actually getting care. You're safe. You're keeping you from doing any harm to yourself or anybody else. But, largely at the end, they come out of those experiences and they're highly traumatized. Now, I send them to you and you're doing an assessment on this person. It's like, okay, well, now they have a trauma disorder based on an experience they've had with a hospital, in addition to whatever condition that caused them to get there. So we have to add that into the mix. And all of a sudden, you've got this picture, and you've got a treatment that's got to complement all the various pieces and be able to address them in the way that they need to be addressed.
I will say, just to come full circle back to the beginning of the conversation, that's why I'm so passionate about like assessment for neurodivergence because
Absolutely.
because you can't assume that a young person on the spectrum just presents with anxiety and depression, emotional regulation, all these kinds of things, and that it can be conceptualized the same way as like a neurotypical young person presenting with the same
Exactly.
symptoms. The symptoms might look the same, but the mechanism underneath them may be very different. And when you're doing a biopsychosocial, when you're doing a psychiatric interview, it's very difficult to see those things, if possible at all. Like most good clinicians, they know a mood disorder when they see it. They know an anxiety disorder when they see it. OCD is misdiagnosed 40 to 50% of the time. And as soon as you start having personality or trauma or developmental issues, it gets very cloudy very quickly. And neuropsych's the best way of kind of disambiguating those things. But that distinction really matters because it helps to formulate treatment. And again, at the end of the day, the goal here isn't to make an autistic person less autistic, right? The goal is to identify what's causing suffering, what's interfering with someone's functioning, and how we can help that person build a life that works for their brain.
Right.
Um, the value of testing over and above the kind of standard forms of assessment in treatment.
And I'm going to say something that I'm curious to see your reaction to, which is the DSM is not very good at,
Pass. Not touching that with a 10.
as in there's a bucket, and and I'm gonna keep pitching. Oh, they've got this symptomology and that symptomology. They've got anxiety and they've got depression, and I keep pitching these things. And if I put enough things in the bucket, it weighs on the scale of a diagnosis, and the diagnosis pops up. And I'm not saying it's not a useful mechanism. I'm saying that without training and insight and experience, it can lead a person to just do it, just throwing things in the bucket, watching whatever it is that rises, checking the boxes, putting the diagnosis down, etc. Without a person, and that's why we've gotten to where we are with people on the spectrum, where they've been diagnosed improperly, treated improperly, and you get to a person like you who's like, all right, I need to form a relationship with this individual. I need to look beneath the surface of what we might see these former diagnoses having been. I need to really form a picture of what has gone on in their lives and how it is that we can come up with something that's going to help them lead a better one. And so there's a real like gift to doing good assessment. The person who's doing it has got a gift for being able to get to the root of it. And that is something that I think that you're accomplishing, which I'm grateful for, which just leads me to this question. How did you get into this? Where did you
Well,
start?
you also give me so much to address there before.
Oh yeah. I know I'm terrible. It's
It's so
terrible.
rich, but the DSM is really interesting because it does allow for a lot of misinformation, a lot of self-diagnosis. Anybody can look up the DSM and say and identify with the things that they're seeing. Um,
Hmm.
I mean, what comes to mind is like to paraphrase Churchill about democracy. The DSM is the worst form of, government except for all the other forms that we've tried. Um, you know,
Right, right.
it's the best that we have. And it's and they spend an enormous amount of time validating. I mean, the first DSM, the disorders included homosexuality and nostalgia, right? So like we're on DSM-5 revised. Like these disorders that have remained are empirically validated disorders. And the issue is so often that there's a co-option of clinical language. People on the street love to say, I'm depressed and anxious, and rightfully so. The world is a sad and stressful place, but they mean I'm sad and I'm stressed. When I say somebody's depressed, it means they meet 5 out of 9 criteria for major depressive disorder in the DSM, right? So that's when people say I'm depressed, and their friends say, I don't know, take a shower, go on a run. That's not really capturing. That's not they don't necessarily mean depression, and that's not a real treatment recommendation, right? So I think that kind of disambiguating uh, kind of like a colloquial usage of our clinical terms and what a psychologist means is really important. Um, so in terms of how I got into it, they don't let you try therapy. They don't let you like try it out to see if you like it. There's no sample where you get to be someone's therapist and see if you like it. So you don't get to do it until you're in a PhD program for psychology, which means you've committed to therapy for the rest of your life in terms of time and money and energy and all the things you put into it. And I sat down and I was a therapist for several years. And it was not for me. It is such important work. All my friends are therapists, and they they are help people transform their lives. Um, and
They love doing it.
they love doing it. And there were definitely moments where I felt like I really made a difference. But I used to kind of glibly say that when I was a therapist, I used to sit, wait to have a gut reaction, and then try really hard not to tell somebody what I think they should do. And now my job is to collect as much information as humanly possible about somebody and then tell them exactly what I think they should do. Uh,
Right.
now I bring the horse to water, right? My job is to say, the water's full of lithium and you're a really thirsty horse. It is not my job to make them drink it. My job is to kind of empower people with data, which is much more egocentric for me, right? I like more information. I want to be able to make informed decisions. And I try to help people do that. Whether or not you're a client or a family or a clinician or a consultant, my job is to try to get everybody on the same page and at least have one set of mutually agreed upon valid data.
Yeah, your job is to bring them the water. My job is to convince them to drink it.
That's correct. Exactly. That's exactly right. And then a therapist's job
Whether
is to
it's treatment or
scoop
meds.
the
Yeah,
water.
right.
Exactly. Scoop the water into the
Right.
horse's mouth. I know. I get it.
Look, I'm telling you, this water's going to taste really good. I promise you. Just give it a minute.
Exactly right.
David, it has been, I just enjoy hanging out with you, and I enjoy hearing your insights about the field. I enjoy having you as a person out there doing really solid work because I think we need more of you. So this has been Head Inside Mental Health. Todd Weatherly, your host. Been with Dr. David Rowe with United Assessment. Seek him out if you need good diagnostic work for mental health or co-occurring disorders. He really does know what he's doing. Thanks for being on the show.
Thank you, Todd, for having me.
We'll look forward to being with you next time. Be well.
I feel so lonely and lost in here. I need to find my way.